Hello and welcome to this video lecture on the factors that influence the design, delivery and evaluation of health promotion and public health projects. In this session, we will discuss two models for systematically analysing the factors that need to be thought about when designing, delivering and evaluating public health and health promotion projects. These two models are the evidence-based practice model developed by Cytofield et al. And the ecological model developed by Brof and Brenner. Both models are useful. They provide different perspectives on the factors that influence project design, delivery and evaluation. Projects are more likely to succeed when they have thought about all the factors that may affect a project, either positively by making it easier for people to take part in the project, or negatively if it makes it harder for people to take part in the project. Cytofield's model is a useful starting point, and it identifies four key factors that influence the design, delivery and evaluation of health promotion and public health projects and programs. In this model, Cytofield et al. Identify four key factors. The first factor is the client or population's characteristics, their current health status, their current needs, their current values, and their preferences in relation to the kinds of projects and programs that they would like. Their values links to their beliefs and attitudes, and these could be religious beliefs, but they could also be political beliefs and also beliefs about how health projects should be designed, delivered and evaluated. The second factor is the wider environment and the organizational context, which is the organizations that are going to design, deliver and evaluate the health promotion project. 3 is what is the best available scientific research evidence, and what does it say about what is likely to be the most effective health promotion intervention. And 4, what resources, time, people, money and practitioners' expertise and skills will we need to successfully deliver that project. Planning, implementing and evaluating health promotion projects therefore involves thinking about all these 4 domains. This Venn diagram shows the relationship among 5 concepts, the 4 key factors, and then the center factor, which is the decision-making factor, as you can see here. So the 3 circles in the middle of the graphic overlap with each other, and these are population characteristics, needs, values and preferences, best available research evidence and resources, including practitioner expertise. On top of these overlapping 3 circles, in the center is the circle of decision making. And then around all these 4 elements is the environment and organizational context. So let's just go back and look at that again. So you can see there the 1, 3 and 4 factors: client population characteristics, state, needs, values and preferences, best available research evidence and resources including practitioner expertise overlap between each other and through all 3 of them. And this is overlain by the decision-making circle. This is the point where all 3 elements come together and we make a decision about how we are going to design, deliver and evaluate the project. And around these 4 elements is the environment and organizational context, which influences all these other factors. So let's look at the first factor, population characteristics, needs, values, and preferences. So remembering back to the precede and proceed model, we can split the needs assessment into the social assessment and the epidemiological assessment. The social assessment is what's important to local people, your target group of children, young people, women, older people. And in the first step of that process, we ask local people what they want. If they don't want your project or think other things are more important, then they aren't going to use the project. We ask them what they think the major problems are in their local community, both health problems and social problems. We ask them what they think public health professionals should do, what interventions they think we should develop, what would they prefer in terms of the type of health promotion projects we could offer. We ask them what is important to them. It might not be directly about health, diet, physical activity, or some other health aspect, but it may be something else like crime and safety in their neighborhood. We generally use individual interviews of key people, and we use group interviews, sometimes also called focus groups, as well as questionnaires to get feedback from the local community. And we would think about where we will talk about to these people, and usually this is in community centres, places of worship, schools, and on the high street or in a mall. Second, we will look and do an epidemiological assessment looking at population characteristics such as existing health status, determinants of health, and we would also look at deprivation and inequalities, and we would look at demographics, age profile, ethnicity, sex ratio, and so on. And these statistics would help us to know what the scale of the problem is in the local area, and also we would need to think about, and we would be able to make a judgment on what the quality of the information is and where we might get good quality information. Key sources are Office for National Statistics, community profiles from the Department of Health, local authority information units, and departments of health. Secondly, we would consider information on the determinants of health, and often these are in the health profiles and statistics that we can gather from existing organisations that collect this information, such as Public Health England, Department of Health, Office for National Statistics. And so this information, the social and epidemiological assessment, can also help us with monitoring and evaluation. The outcomes, the information we get about quality of life issues can be used to develop indicators through which we can monitor and evaluate the project. And in this context, you can see here, if we start at the bottom, we have a range of health promotion actions such as education, facilitation, and advocacy, and that leads to a range of different outcomes such as health literacy, social influence and action, healthy public policy and organizational practice. And through these health promotion outcomes, we get intermediate health outcomes such as improvements in healthy lifestyles, better and more effective health services, and more healthier and safer neighborhood environments. And these in turn then lead to more specific and direct health and social outcomes such as changes in mortality, morbidity, and disability. Mortality is the number of deaths. Morbidity is the number of people with a disease, and of course disability in terms of the numbers of people having a chronic disability. And these will also feed into wider social indicators such as quality of life, the ability to function independently, to be able to wash and dress ourselves and go and work and do something interesting and useful to the person and the wider community. And also we can look at equity and inequality issues. So the social and epidemiological assessment can feed into how we might look at monitoring and evaluating the final project. Second is the wider social, economic and environmental context, and we look at this second because the wider social, economic and environmental context affects the other three aspects. And the best way to look at this is by using an ecological model, and here is one example of an ecological model, and you have looked at this before in previous modules. We start with individual or population health, and we can think of the person and pathophysiological pathways. We can look at their genetic factors, and we can look at their individual risk factors, and all of these things is part of the individual. Then we can look at their social relationships, whether they have good friends and family support networks, and then we can look at their living conditions, such as what kind of housing they live in, what kind of neighborhood they live in, what kind of job in terms of income and job security that they have, and then look at the wider neighborhood and the communities they live in, and whether these are safe, whether these have the services and amenities that make it a nice, safe, welcoming neighborhood and community to live in. And then following that, we can look at the institutions such as the local council, health and social care services, education, housing, leisure, the institutions that deliver the range of services in our community. And finally, we can look at the national level at social and economic policies that influence all the other things. Now, by looking at each of these aspects, from the individual to the family to the neighborhood and community and to the national level, we can get a good idea of what the implications of different factors are. For example, we could have changes in social and economic policy that have an impact on the funding or the value priority of the health promotion project that we want to develop and implement. Or we could find that the kind of neighborhood and community that we want to work in would not like the kind of health promotion project that we are interested in, or that we have tried a similar project before in the past and that has not worked. So we need to look at why that might be before we redo the project in a similar way to what had been done previously. The other model is Brenner's ecological framework, and this is interesting because at the bottom he has time, because over time things change, and over time social, economic, cultural and personal factors change, and that can change the factors that affect our project. And so in the center is the microsystem, and that is the person and the networks that they have: family, health services, church group, neighborhood play area, their family, their friends and their school, and the other amenities and services that are available in the community that the person lives in. The mesosystem is the relationships people have with other people, with other microsystems, in Brenner's words, so that it's our relationship with others, and that is the mesosystem and how that interacts with us and our health and well-being. And the exosystem is our wider family and friends and neighbors, and the wider sets of services that we might have, such as mass media, social welfare and other wider services that we may not use so often, legal services, financial, etc. And then the macrosystem is the attitudes and political ideologies and beliefs of the culture that we are living in. So you can see here, this model, while it looks very different visually, is actually quite similar to the model here. It's just visualized in a slightly different way. You can see here that time is also involved in this model, because there is the word life course at the left hand side, and this shows that all these relationships, these risk factors, these institutions are also changing over the life course of an individual. And on the bottom right hand side, they also have the environment, the wider environment that impacts on people, again picking up on the other wider issues beyond this, the natural environment, for example, that affects individuals and communities and social and economic policies. So how do we use this kind of model? Well, before we do that, let's just have a look at explaining Bronfenbrenner's model, and that is the macrosystem is the cultural, political and ideological factors that influence the microsystem, the person and their relationships at the very local level. It includes prevailing political ideologies in terms of what politics is seen as normal and what is not seen as normal. It also includes individuals' own social class, ethnic group and the wider culture. The exosystem is the social network, the workplace people are working in, and the health and social care and other organizations that are there to support them. The mesosystem is, as I said before, the linkages between different individuals' microsystems. The microsystem is the concrete activity as experienced by individuals in terms of their relationships with others. For example, a parent and child relationship, that is part of the microsystem that affects people's health and well-being. And then the chronosystem is the patterns of events over time. As I said, just going back to this version, so you can see we are in the microsystem. It's the relationships that we have at the local level, almost family level, at the kind of household, street level. And then we have the mesosystem, the interactions we have with other microsystems outside of the family. And then we have the exosystem, which moves outwards. It's more about neighborhoods and communities. And then the macrosystem is the national, societal level and the implications of that level on the individual. So how do you think the factors on the left might be defined? So here's an example of a table, again using the ecological perspective, again slightly different. So you've got the intrapersonal factors, the factors within the individual. You have the interpersonal factors, the factors between an individual and other people. And then you have the community level factors, and they've been broken down into three elements. Institutional factors in terms of the kinds of organizations and institutions that are out there delivering services. Community factors, the issues within the community that the person lives in. And then public policy, the wider local and national policy that has an impact on the person. So the intrapersonal level are the individual characteristics that influence behavior, such as knowledge, attitudes, beliefs, and personality traits. The interpersonal level are the processes and primary groups, including family, friends, and peers, that provide social identity, support, and role definition. Institutional factors are the rules, regulations, policies, and informal and formal structures which may constrain or promote recommended behaviors. Community factors are the social networks and norms which exist as formal or informal standards among individuals, groups, and organizations. And lastly, public policy are the local, state, district policies and laws that regulate or support healthy actions and practices around prevention, early detection, control, and management of disease and illness. I hope you can see that this model also is very similar to the Bronfenbrenner model and to the other model that I showed you. This one and this one. So the third factor is evidence, theories and approaches, and this is focused mostly on scientific evidence and scientific theories and approaches. Remember the previous modules that you have been looking at for scientific evidence in year 1 and year 2. Key elements of this are about engaging the community in assessment and decision making, using data and information systems systematically, making decisions on the basis of the best available peer-reviewed evidence, both quantitative and qualitative, applying program planning frameworks, often based in health behavior theory, conducting good quality evaluation, and disseminating what we have learnt from designing, delivering and evaluating the project. And what kinds of theories and approaches are we talking about? Well, here's an example. So we can either change people's behaviors, or we can change the wider environment they are living and working in. And examples of changing people's behaviors are educational sessions and interactive kiosks providing information. We could do print brochures and leaflets. We could do a social marketing campaign. And often this activity is at the individual level, and the kinds of theories that we may use are the stages of change model, the precaution adoption process, the health belief model, and the theory of planned behavior. Now here you can see here theories and models are often used interchangeably, so don't worry, a model is often very similar to a theory, and at this level you don't need to worry about the difference between the two. Models generally are more restricted, they're more visual, they have more specific elements within them, while theories are more broader and more general in application. Moving down to something that might affect people's behaviors as well as change the environment to some extent are mentoring programs and lay health advising, and that works at the interpersonal level, at the family level, at the friends and peer network level. And for that set of activities we might use the social cognitive theory as a way to think about and to design and to deliver our project. Lastly, in terms of focusing more on the wider environment, we may look to do media advocacy campaigns, or we could advocate changes to national government policy or business policy or the individual company policy, and that would work at the community level, the neighborhood level, or it could work at the societal level nationally. And the theories we might use for that kind of intervention and activity would be communication theory, diffusion of innovations theory, and community organizing theory. Last, we come to resources, and this is about the knowledge, skills and experiences that you and your team have. It's also about your organization's power and influence and expertise, and it's also the partners that you have, the community, other departments in your organization and other organizations. Lastly, it's about the time you have, the money you have, and the skilled people you have in your team, in yourself, in your organization, and in your partners. Well, I hope you found this a useful session, and I hope you picked up a few things while thinking about how you might tackle looking at the range of factors, the social determinants of health, and how you can do that systematically using two broad models, the Bronfen-Brenner model and the Cytofield model, and the Sedgley model, which is very similar to the Bronfen-Brenner model. Just a reminder to do some further reading and look up some of the issues and concepts and ideas and theories that we've talked about. Thank you very much for listening.